Good evening to all. We are conducting our journal club of IAP Thiruvananthapuram. Warmly welcome you all to this edition, this episode of journal club. As we know, we are conducting this journal club with the interest of academic useful for practicing pediatricians, for updation, and we are trying to keep the quality of our journal club with articles from national and international index journals. It will be useful for the research advances paper for the PGs also, and we are trying to do it in a regular fashion. So this is the fourth session where we will be dealing with a very relevant topic, and we will be dealing with the article, a systematic review of studies from India regarding MIS-C, which was published in Indian Pediatrics in July 2022, volume 24. And as you all know, today the two PGs from Ananthapuri Hospital, Trivandrum, will be doing the presentation as well as analysis. And the expert analysis will be done by Dr. Ramankutty sir. Sir is a lecturer in started as a lecturer in pediatrics at Medical College. Sir is a research scientist, Emeritus Professor, senior grade at Achuthamenon Center, Sri Tirunal, Center for Medical Sciences and Technology. His sir is an advisor of the Kerala State Planning Board also. And from Ananthapuri Hospital, we have Dr. Kamala Swarnam Madam also. Okay. Madam is the senior consultant at pediatrician neonatologist at Ananthapuri Hospitals and Research Institute, heading the pediatric DNB program. And Madam is MD DCH, BBS from the GMC TVM, MD DCH from Kottayam, and the neonatology fellowship Madam has obtained from Calgary, Canada. Madam is having the fellowship in perinatal neonatal medicine. And the journal club coordinator is Dr. Achuthamenon sir. Sir is also with us. Sir did his MD Pediatrics from Medical College Trivandrum and has sir is MRCP and MRCPH. Presently working as a senior consultant in Pediatrics PRS Hospital. Sir has teaching experience in Medical College Trivandrum and has papers published in index local and international journals. Now today's journal will be presented by Dr. Amina Shamsudeen. Madam is a DNB resident at Ananthapuri Hospital Research Institute, and the analysis will be done by Dr. Ancy, DNB resident, Ananthapuri Hospital and Research Institute, Trivandrum. So, without losing anything, we will directly go to the journal club proper. And before that, I would like to request Dr. Achuthamenon sir to give some opening comments.
And all the best for today's journal club. Congrats, Dr. Kamala. Congrats, Dr. Amina and Ancy. And thank you very much. Thank you very much for Anshu and Padmanabhan sir for coordinating this very nicely. And very, very important is to thank Ramankutty sir. And he is contributing for each and every event of this journal club very much. Thank you very much for the effort taken, sir. Thank you. Anshu, please carry on with your journal club. I don't want to waste much time.
Thank you so much, Dr. Puni Madam, President IAP Thiruvananthapuram. And I would like to request the opening remarks from Dr. Padmanabhan sir.
So the opening remarks, I hope you can hear me. The opening remarks is just that we are thanking the Ananthapuri Hospital for taking active interest in participation and also sending their two PGs for this journal club. We are trying to widen the base. We have first included the PRS hospital, and then we had the KIMS hospital. I think the second was SAT, and now we are having the Ananthapuri. Therefore, that's a great thing. Therefore, I don't want to waste any more time. Let's go back to the presentation straight away. Thank you.
Thank you, Padmanabhan sir. Now we will go to the journal club session proper. And I would like to request Dr. Amina, doctor from Ananthapuri Hospital, to present the article. Dr. Amina.
Good evening, all. Am I audible?
Yes, madam. We can continue.
Good evening, all. Today, I'll be presenting an overview of the journal club. The title of the journal is Multisystem Inflammatory Syndrome Associated with COVID-19 in Children, or MIS-C. a systematic review of studies from India. The article was published in Indian Pediatrics, volume 59 on July 15th edition. And the authors are from PGI Chandigarh. Coming to the introduction, a minority of children infected with severe acute respiratory syndrome coronavirus 2 present with multisystem inflammatory syndrome in children, usually 2 to 4 weeks post-infection. The pathophysiology of which is still unclear. The clinical features overlap with Kawasaki disease, toxic shock syndrome, and secondary hemophagocytic lymphohistiocytosis or macrophage activation syndrome. The incidence is approximately 2 per 1 lakh children under the age of 21 years. And the current review addresses the question of clinical manifestations, laboratory profile, and therapeutic strategies employed for MIS-C in India. And the aim of the current study was to gather data from Indian population and present it in the form of a systematic review. Coming to the methods, this systematic review was done as per the PRISMA guidelines, and quality assessment was done using the NIH tool for case series. The NIH tool is a set of quality assessment tool to assist reviewers to focus on the concepts. A systematic search through databases yielded studies whose data was pooled to calculate the mean frequencies with standard deviation using the GraphPad software. And it is a software that is formatted for the analysis, including the study on quantitative and categorical variable, and creates graphs. And the article detailed participants, that is children with MIS-C, exposure, it is coronavirus disease 19 infection, an outcome as types of organ system involved, common clinical features associated with MIS-C, treatments used, and the values of laboratory parameters. The eligibility criteria for studies are the case series on MIS-C from India published in English till December 2021 were included, and case definitions as per CDC, WHO, and RCPCH criteria were considered. And data related to other coronaviruses were not included, and SARS-CoV-2 positivity, either by a real-time RT-PCR positivity or serology, was considered essential. And studies on adults were also excluded. Coming to the selection process and the data collection, full text of articles were retrieved, which were further screened by 2 authors as per the inclusion criteria. Finally, the articles were selected by consensus for inclusion in the review, and a structured form to record the details was prepared to extract various parameters from the included studies. And the data extraction was done independently by the 2 reviewers, and any conflicts were resolved by discussion or by consulting a 3rd reviewer. Data on age, gender, number of participants, MIS-C case definition, diagnostic criteria, clinical features, treatment regimes, laboratory parameters, and features of Kawasaki disease were noted. And 2 authors independently did the meaning of titles and abstracts. Into the findings and clinical features, fever was present in 100% of cases, and it was followed by mucocutaneous symptoms. So there is 72% of the kids had mucocutaneous features, manifested as a rash for 53.5%, conjunctivitis for 54.3%, and oral cavity changes in 27%. And gastrointestinal symptoms were seen in 62%, manifesting as abdominal pain in 54.7%, and diarrhea and vomiting in 51%. And cardiovascular symptoms were seen in 54%, and respiratory system was involved in 42% of cases, and the neurological involvement was seen in 32% of cases as headache, seizures, or altered sensorium. And in one study, 35% of cases reported to have acute encephalitis-like illness. And features of Kawasaki disease were seen in it varied from 4 to 76% in all studies. And dengue-like illness was seen in 20% in one case series. Coming to the laboratory parameters, coming to the inflammatory markers, all studies showed an elevation of inflammatory markers with CRP showing 93% of elevation. In 93% of studies, CRP was positive, and the range was between 96 to 473 milligram per liter. And those studies which had checked interleukin-6 was also found to be elevated, that is 43 to 527 picogram per ml. And D-dimer was also elevated in 85% of cases. Coming to the hematological abnormalities, lymphopenia, neutrophilia, thrombocytopenia, and anemia was found. The biomarkers of cardiac dysfunction like high pro-BNP and high troponin levels were also found. Pro-BNP was elevated in 82% of cases and troponin was elevated in 34% of cases. And echocardiography revealed left ventricular systolic dysfunction in 41% of cases and coronary dilation in 28% cases. And 2 studies showed arrhythmia.
Amina madam, can you unmute yourself actually and speak?
Okay, sir.
Continue, please. You can continue, madam. Amina, continue. Thank you.
Coming to the management, corticosteroids were given in 76% of cases, and intravenous immunoglobulin was given in 62% of cases. Inotropic and vasoactive support was given in 49% of cases, and anticoagulative drugs were given in 69% of cases, and antibiotics were given in 90% of cases where indicated. And the immunomodulatory agents like tocilizumab and infliximab was given in 8% of cases. And mechanical ventilation was also employed in 29% of cases. And in one study, adrenaline and noradrenaline was used in 80% of the admissions. Coming to the discussion, the majority of children reported were aged around 7 years with a slight preponderance of males. And the mortality rate in the current analysis was found to be more than 10%, which is much higher than less than 2% mortality rate reported in other studies. And Kawasaki disease-like features were also more commonly associated with male gender. And a poor prognosis in males could be explained by the ACE2 expression, the transmembrane protease serine type 2 gene, and the hyperinflammatory immunological response, which is general in males. Fever lasting for an average of 6 days was seen. As compared to other febrile conditions, children with MIS-C had a higher reported temperature and a greater duration of fever. And a preponderance of mucocutaneous features was found with less common respiratory features. An acute abdomen is a characteristic feature of MIS-C, mostly due to non-surgical intestinal inflammatory pathology. And more than 50% of children in review reported cardiovascular changes, just like the previous reports. And the treatment is partly dependent on the presenting condition of the patient and has been evolving with the availability of a wide range of therapeutic options. Unlike in adults, the use of antivirals and convalescent plasma therapy was infrequent, and a better clinical efficacy reported to be achieved with treatment of IVIG together with methylprednisolone as compared with IVIG alone. This remains a multifaceted disease and hence poses a difficulty for treating clinician to decide on the course of its management. There are certain limitations of the study. The heterogeneity among the included studies would have led to an over or underestimation of some parameters reported in the current review. And data reporting was quite variable among studies, and the effect of various comorbidities and any underlying risk could not be assessed because of the insufficiency of data in this regard. Coming to the results and conclusion, screening of 2,548 articles published till December 2021 yielded 11 case series, and the World Health Organization case definition was used widely. And there was a slight preponderance of males with 57%, and their median age was 7 years. And 63% required intensive care unit admissions, and mortality range was nearly 10%. And the clinical features included fever, followed by mucocutaneous features and gastrointestinal problems. Kawasaki disease-like features were not reported in many studies, but it ranged from 4 to 76%. An increased level of inflammatory markers and derangement in other parameters were seen just like previous studies. And widely used treatment was corticosteroids and intravenous immunoglobulin with other options depending on the patient's state. And many studies, further studies are required for the further development of treatment in this MIS-C. And many such studies are ongoing and the results are awaited. And this systematic review provides adequate evidence from Indian population that will help pediatricians in a better management of this disease. Thank you.
Thank you, Dr. Amina, for that precise and concise and crisp presentation. Now we will go to the analysis part. I would like to request the doctor who has been used, that is Dr. Ancy Paul. I would like to request Dr. Ancy to present the analysis. Thank you.
So good evening all. I'm Dr. Ancy. I'll be doing a statistical analysis of the this review article. So here I'm using PRISMA guidelines for the critical appraisal of this review article. So before entering into the analysis, we should know what is PRISMA. PRISMA is preferred reporting item for systematic reviews and meta-analysis. It's an evidence-based minimum set of items for reporting in systematic reviews and meta-analysis. It's a statement consists of a 27-item checklist and a 4-phase flow diagram. So who is PRISMA for? This PRISMA is used by authors. It helps authors to improve the reporting of systematic reviews, and it can be also used by journal peer reviewers. It's useful for critical appraisal of the published systematic reviews. Why PRISMA is used? Because PRISMA is the recognized standard for reporting evidence in systematic review. The benefits of using PRISMA is it can demonstrate the quality of the review. It can allow the readers to assess the strengths and weaknesses, and it can permit replication of the review methods, and it can be able to structure and format the review using PRISMA headings. So there is both PRISMA checklist and PRISMA flowchart is there. PRISMA checklist, it's a 27-item PRISMA quality checklist broadly divided into title, abstract, introduction, methods, results, discussion, and funds. And PRISMA flowchart, it's a flowchart is based on 4 things: identification, screening, eligibility, and the included studies. So now we will analyze this review article using PRISMA framework. So there are 27 quality checklisting. The first item is title. For this PRISMA, according to this PRISMA guideline, in a title of systematic review, from this title, we should identify the study as a systematic review. In our study, it's clearly mentioned that it's a systematic review of studies from India. So the title, the item number 1 is qualified. And the item number 2 is abstract. As PRISMA guidelines, there is a quality checklist for abstract, and it contains 12 things. And the first is title of the abstract, and it's in that title also, we have to identify the report as a systematic review. It's clearly mentioned. In the background, we have to clearly mention the objective that they are mentioned in the abstract. In the methods, the eligibility criteria of the studies and where these studies were taken and the risk of bias of these studies should have been mentioned, but it's not mentioned in the abstract. But the methods used for the synthesis of the result is mentioned in the abstract. And the result area, the included studies have to be mentioned, and the result for main item has to be presented, and both things are qualified in abstract. In the discussion area, the limitations they haven't mentioned, and the interpretation of the result is they have mentioned. And the other things we have to check is the funding of the study and the registration of the studies that they haven't mentioned in the abstract. So after this 12 things, the only 6 items are qualified for the abstract of this study. Item number 3 is introduction. In introduction, we have to look the rationale of the study is clearly mentioned, or objective of the study is mentioned. In the introduction, the authors mention that there is a lack of clear understanding of the pathophysiology of MIS, but the case definitions of the MIS are already available. And here they are discussing the clinical manifestation, lab findings, and therapeutic strategies. But the rationale for doing the study is not clearly mentioned. And in the introduction, ideally, they have to mention the objective clearly. They clearly mentioned that the aim of the study is to gather data from Indian population and present it in a systematic review. That they are clearly mentioned in the introduction. Next are methods. In the methods, the first thing we have to look is the eligibility criteria. We have to specifically mention the inclusion and exclusion criteria that they are clearly mentioned in the study. The inclusion is they are taken case series on MIS from India published in English till December 2021. And they excluded studies on adults and data related to other coronaviruses they excluded. But for the calculating the results, how these studies were grouped, they haven't mentioned in the methodology. So it's a inclusion and exclusion criteria they mentioned, but how studies were grouped, they haven't mentioned in the methodology. And item number 6 is information sources. In information sources, we have to mention all databases, registers, and websites from where these studies are taken. They have mentioned that they took the studies from PubMed, Embase, and OVID databases, but in this, they have to mention date when each sources was last read, but it was mentioned in the methods. And item number 7 is search strategy. In search strategy, they have to present the full search strategies for all databases, registers, and websites. So they mentioned in a box the key terms applied to search for relevant studies. Item number 8 is the selection process in the methods. In selection process, we have to specify the methods used to decide whether a study met the inclusion criteria of the review. So they mention this inclusion criteria and the selection of the articles in the PRISMA flowchart. And in the selection process, we also have to mention how many reviewers screened each record and whether they work independently or not. In the methodology, they have clearly mentioned that 2 authors independently screened the titles and selected the abstract, and the 2 authors independently retrieved the data. So they have clearly mentioned the reviewers' number and whether they work independently or not. And item number 9 is data collection process. In data collection process, we have to specify the methods used to collect data from the reports and how many reviewers collected the data from each report and whether they work independently or not, and the process for obtaining or confirming data from study investigators. So they have mentioned that the methods used to collect the reports, they used a structured form, and how many reviewers collected the data, they mentioned that 2 reviewers collected the data and they worked independently. And the confirming data from study investigators are not useful in our study, so it's not applicable. And item number 10 is data items. So data items, we have to mention all outcomes for which data were collected. They were the outcome of the studies were clinical, overall clinical manifestation, lab findings, and therapeutics. So they collected all the details essential for these outcomes, and other variables also they have collected and they have mentioned in the methodology. And item number 11 is risk of bias assessment. The risk of bias assessment, there are in the risk in a systematic review, there is a selection bias is there, and there is a reporting bias. The selection bias is the bias included in the selection of the studies, and the reporting bias is the bias included in the reporting of the individual studies selected for the systematic review. But the risk of bias assessment of the individual studies were not done in this systematic review. But the selection bias, we can tell that they mentioned 2 authors independently screened the title, and 2 authors independently selected the full article, and again 2 authors independently reviewed the article. From that, we can assess that the risk of selection was avoided, but the assessment of risk of bias of the parent articles were not done. And the item number 12 is effect measures. And in this, we have to specify for each outcome the effect of measures like risk ratio or mean difference used in the synthesis or presentation of the result. So in this study, the findings from individual studies were summarized in summary table, and data for these variables were pooled as relative frequencies and presented as mean and standard deviation. And item number 13 is synthesis methods. In synthesis method, we have to describe the process used to decide which studies were eligible for each synthesis. So this is the Prisma flowchart. So using Prisma flowchart, they have selected the studies. In Prisma flowchart, we can see that initially they selected 2,548 studies totally from PubMed, Embase and Ovid. And since 246 studies were duplicate records, they removed, and out of 2,302, 942 were excluded because of different study design. Studies were not from India and studies were not done in children. And from this data, they selected 55, and from that, they included 11 studies for quality check. So after the selection, they did a quality check of each study. So as Dr. Amina said, the NIH tool is the tool used for the quality check of the study selected for the systematic review. This is the format of NIH tool. So in this NIH tool, they will look, was the study questions or objective clearly stated? Was the study population clearly and fully described? Were the cases consecutive? Were the subjects comparable? Was the intervention clearly described? Were the outcome measure clearly defined? Was the length of the follow-up adequate? Were the statistical methods well described, where the results well described, and quality rating they have mentioned. And for the 11 studies, they did a quality check and selected. In this, we have a study from Trivandrum by Shamsudeen madam, and almost all the criteria were fulfilled by that study. And item number 13 is the synthesis method. Synthesis method means how we are calculating the result of the study. Ideally, for a systematic review, we will use meta-analysis for the formation of the result. But in the health sector, usually the meta-analysis were not fully used. Sometimes they will use a narrative analysis also. But here in our study, they haven't mentioned which method they use for the calculation of the data and what is the rationale for the heading. And but they have mentioned the methods used to tabulate or visually display the results, like the individual studies were summarized in summary tables, and the data for these variables were pooled as relative frequencies and presented as mean and standard deviation. As I said, any methods used to synthesize the results were not mentioned, and the rationale for the choice of the method was also not mentioned. And the heterogeneity among studies were not properly explained, and the sensitivity of the analysis of this study was not clearly mentioned. But the result of individual studies were quality check, but result of this systematic review was not fully, the quality check was not done fully. And the 14 and 15 item was reporting bias assessment and certainty assessment. Reporting bias assessment, as I said, for individual studies selected for this systematic review, we have to assess the risk of reporting, means for individual studies, whether there is any bias in reporting of the items which could have been skewed the data of individual studies. But in this study, they haven't mentioned about the reporting bias assessment of the individual study. And certainty assessment is the how accurate is our outcome. These two things were not explained in the study. And item number 16 is the study selection. As I have mentioned, they used a Prisma flowchart for the selection of studies. After this, these studies went through a NIH tool quality checklist. So they selected the studies using a Prisma flowchart. And the item number 17 is study characteristic. Here we have to cite each included study and present its characteristic. So in a table, they mention all the 11 studies and the major, the demographic features were calculated in a table, but the clinical manifestation, the therapeutic things and the lab values of individual studies were not grouped. Only the demographic findings were grouped for individual studies. And the item number 18 is risk of bias in studies, that they are not assessed. They haven't mentioned about the risk of bias in individual studies. And item number 19 is a result of individual studies. Only the demographic features and the lab values of individual studies were mentioned, but the clinical features and the therapeutic intervention of the individual studies were not tabulated in a proper way. And item number 20 is result of synthesis, and they presented the result of the that means the outcome of this study as this bar diagram and pie chart. The demographic characters they presented as a bar diagram, and the clinical manifestation they presented as a pie chart, and also they have properly used a graphical representation for the result of the outcome of the systematic review. And along with this, for each synthesis, we have to briefly summarize the characteristic and risk of bias, but it's not mentioned. And we have to also present result of all investigations of possible causes of heterogeneity. That also they haven't mentioned. And the sensitivity of analysis of each result also have to be addressed, but it's not mentioned. The item number 21 and 22 is reporting biases and certainty of the evidence. That's also not mentioned in the study. And item number 23 is the discussion. In discussion, we have to provide a general interpretation of the result in the context of other evidences that they have clearly mentioned, like in the context of Indian population, they have done the study and they have clearly mentioned the limitations included in the review, and they have mentioned the limitations of the review also, and they have clearly mentioned the implication of the result for practice, policy, and future. They have proposed a future study for the further follow-up of the MIS also. They have mentioned all the discussion part clearly. And the item number 24, 25, and 26, 27 include other information. First one is the registration and protocol. They haven't mentioned anything about the registration of the study or protocol, where we any changes that made during the during the submission of the protocol, they haven't mentioned. And the support of the study, they have mentioned. Here they have to mention the financial source. They have mentioned the ICMR funded the study, and in competing interest we have to mention whether there is any competing interest. They have mentioned none. And the fourth thing is availability of data, that is from where we can assess this study. They have mentioned the additional materials related to the studies available with the online version at www.Indian Pediatrics. So these were the 27 things we have to check to do the quality check of a systematic review. So this is the PRISMA format of this checklist. That is the 27 item checklist used for the critical appraisal of the systematic review. The green thing mentioned, where the data fulfilled, and the red thing mentioned was the data not fulfilled in the systematic review. So overall, only 25% of the things were not mentioned, but the main data and major things were clearly mentioned in the systematic review. That's all. Thank you.
Thank you, Ancy, for that brilliant micro dissection of the article. Now we will go to the expert analysis. I would like to request Dr. Ramankutty sir to share his thoughts with us. Dr. Ramankutty sir.
Yeah, can you stop sharing this? I mean, still I can see the screen. Yeah, so am I audible?
Yes, sir.
The first thing I would like to say is that both the presentations were excellent. So I'm very happy that The residents are very keen and they're picking up. And also it reflects on the quality of the training because they have been trained very well, which is very commendable. Actually, my job is very easy because this article, review of this article is very easy because this is actually a systematic review of a particular syndrome, that is multisystem inflammatory syndrome in children after COVID-19. So what is a systematic review? Now, I think many people think that systematic review is just a review, literature review, which is not true. Systematic review is really like a research study. So that is what one of the take-home messages should be. It is like, it is part of the evidence synthesis that we see. If you look at the evidence pyramid, you find that at the top you find systematic reviews and meta-analysis. So they go together. So systematic review means whatever evidence is available in the literature, you try to collect that and then you synthesize that, the evidence synthesis. That is very important in modern medicine, especially in the current era. Of course, so this is a very laborious process. So systematic review is not something that can be done just in 1 or 2 days or weeks, but actually many systematic reviews take many months. And what is important is to remember that it takes teamwork. So if you look at the flow chart, you will find that they have started with around 2,500 studies, and they have listed all the databases that they have searched. Of course, nowadays you find that searching using the electronic device tools is very easy, whereas in our time, you had to go to the library and physically search for articles, and you could only come up with a few articles. Now you have 2,500 to choose from, but then you have to filter it through and then find out. Finally, you ended up with 11 articles because you had so many criteria. It's very important to remember that, and that flow chart is a very important part of any systematic review. Please remember that in the systematic review, whatever they have mentioned is very important. Like 2 people independently looked at the criteria and looked whether each study which came up in the search was eligible for the review. So if they agreed, then they included it. And if they did not agree, a third person had to come and look at it and see whether they are, whether it is acceptable or not. So that is the way it is done, so that there is no bias. So then after that, then you come to 11 studies, and each one is independently read by one person without consulting the other. And then you look at the biases and all that. So it is a very bias-free process that you have to devise. And these are, and I think very important that you remember that these are all following the PRISMA guidelines. And if you go to the Equator website, which will tell you which are the guidelines for each type of study. So if you want to look at RCTs, then there is one type of guideline. If you want to look at case control studies, there is one type of guideline. So this is all part of the evidence synthesis process. So in this PRISMA guideline, there is a very definite guideline for systematic reviews. So you take all the studies and then you go through the process of looking at the bias, and then you look at, you like to synthesize the evidence from the 11 studies, and that is what they have done. And I think it has been nicely presented by the 2 residents who have attempted to do this, except that I would just say that this is just pointing out something. That is the second person who criticized this. She was, of course, like, that is what I would do also if I were a resident. She was a little more enthusiastic, and I think you can pardon some of those mistakes that you have pointed out, because after all, no study is perfect. So you can actually, especially since this is not a study looking at interventions or cause-effect relationships, it's just descriptive. So sometimes you don't have enough thing to, do that. So then they include some studies which may be a mistake. That is fine. But I don't blame you, but that's a perfectly fine way of doing it, because you have to be critical. That is the whole point of critical analysis, isn't it? So that is fine. That is part of it. So they have done a good job. So finally, they have come up with 11 studies, and they have. But one of the peculiarities of this particular exercise is that usually you do systematic analysis with cause-effect relationship or an RCT or something. But this is just finding out what are the symptoms of a particular condition, which is actually very important, because now we don't know what are the things that actually present as this condition. So it's a very good exercise, and so I think the study is very good, and they have also come to the same conclusion. The people who reviewed also have come to the same conclusion, because we need to know what are the presentation symptoms in Indian population, which is always different from a different the Western population. So now we know some idea. We have some idea of what exactly is the kind of presentation in children in India, which is what the whole objective of the study has been. I think it's a very commendable job. Both the study as well as the presentation has been excellent. And now I think that what is the take-home message? I would say the take-home message is that many people say, we can't do any research in India. We don't have any facilities, which is wrong actually. You do a lot of things. And one of the things you can do is you can attempt systematic reviews, because there is a definite protocol, the definite guidelines. And nowadays, you have all these electronic media at your disposal. You can define a particular research question, look at the studies which have been published, take them out, go through the same process, and maybe get published. And unfortunately, one of the unfortunate things also is that many universities or many institutions think that systematic reviews are not as good as original research, which I think is wrong, because systematic review is a very important exercise and we should do more of them. And I think many of you can attempt to do that. And I would say that each postgraduate or rather the resident before completing the MD should attempt at least one systematic review. So systematic review is a team process, so you can be part of one team looking at one research question. And I think that would be a very good thing, even if it is the university doesn't recommend it or the DNB board doesn't recommend it. I think you can independently do that. I would like to commend the Ananthapuri Hospital for training them in this manner. I think it's very good. And that's all I want to say. I think it's excellent. Thank you very much.
Thank you so much, Ramankutty sir. And now we would like to hear from Dr. Kamala, doctor, who has been the director of the PG training program, as well as the consultant at Ananthapuri Research Center. Over to Dr. Kamala.
Thank you, sir. Thank you, sir, for your very nice words. And let me say that Dr. Elizabeth Madam is also in our faculty, and whatever she has PG'd a lot towards the clinical cases and journals. So we have journal clubs every month. So I'll give all the honor to Elizabeth Madam for training the PGs in such a good way. And of course, Dr. Ancy prepared everything in the last few days, and she has done an excellent job in the review, as Amina has done in the presentation of the case. Sir, Ramankutty sir, can you just explain to them how a systematic review is different from a meta-analysis? What more you have to do a meta-analysis, and a little bit about the biases also. I think we were not very sure about the certainty bias and all. So can you explain that also?
Yeah, actually, a systematic review is very much linked to the meta-analysis, because a meta-analysis cannot take place without a systematic review. So once you have done a systematic review, see if the question can be addressed quantitatively, like what is the OR from all these studies put together? What is the, how can you synthesize? So several studies can have different ORs or relative risk calculations. So if you want to put it together in one table or one figure, then you can have to do a meta-analysis. But in this case, I think
so mainly a comparison happens.
Pardon me?
Mainly there's a quantitative analysis.
That's
and
right.
there is a comparison.
Quantitative synthesis. There are statistical tools for quantitative synthesis we can use.
And there is a comparison also, right, sir? There is a comparison, and everything is put together as a forest plot.
That's right. So each entry in the forest plot tells you what is the strength, what is the number of people in the study, what is the strength of the association, etc., and what is the confidence interval. So it tells you something. And finally, there is one final figure which shows you what is the combined odds ratio or whatever, pooled odds ratios to be technical. But in this study, for instance, they have used the term qualitative synthesis, which means they have not really attempted at one number. but they have tried to synthesize the studies in a qualitative manner, looking at what are the symptoms in the different studies which are predominating, etc., etc. So that is more of a qualitative synthesis. So meta-analysis actually is very much linked to the systematic review. There cannot be a meta-analysis without a systematic review. So there is a first step towards this meta-analysis. So once you have done a meta-analysis, once you have done a systematic review, you can go to the meta-analysis. And at this point, I don't know whether it's fair to say that, but if you have done a systematic review and you would like to do a meta-analysis, I have no problem. I would like to help you. So, you can have no, you can approach me. I don't need any credit, but I would do the thing for you. So,
right, sir.
Part of that. So,
and the thing is, in meta-analysis, you can focus only on one or two questions, right? So here are many different data. So systematic reviews may be an observation study looking at so many different data, but meta-analysis can be done only if we have to focus on one or two items only, right? Relevant.
That is very much true, because systematic review can be, you see, usually when they started with systematic reviews of RCTs. So RCTs address a very one single question, whether it works or not. But then they extended this methodology to other types of studies. Now we have this particular study is only about symptomatology, right? Most of it is about symptoms. So it's descriptive. So they are only talking about descriptive symptoms. So then you can have different symptoms, you can have described many aspects of that. But in a meta-analysis, a study which is amenable to meta-analysis would be focusing on what is the effect measure, like a risk rate or a odds ratio or whatever. So that is what distinguishes the meta-analysis from a systematic review. But systematic review is a prerequisite for any meta-analysis.
Right, sir.
And of course, bias, you talked about bias. Yeah, bias is actually, there are tools for bias analysis. Each study may have certain biases, and you are supposed to go through that exercise of looking at each study, and independently each person has to look at biases, and they have to kind of conflate those. And if there is a difference of opinion, then somebody else has to put in. Same process like in the selection, you have to do in the selection of the quality also. So you have to make sure that all of them have the equal quality or equally free of biases, because bias can occur in any study. So there are tools for this, and of course it's a huge thing. I don't want to get into that at this point in time, but looking at biases is a very important part of doing a systematic review.
Right, sir. And another thing about the systematic review will be the data will be from various institutions or various, so there will be lots of heterogeneity in the collection of the data. So probably the results might not be extrapolated or applicable to the whole population, like whole Indian population. We can't extrapolate the whole the data that we have obtained. That is mainly we have seen that in the data that Amina has presented, the inotrope use in one particular center is more than 80%. So probably that is a referral center leading with more acuity of cases. So that is one issue is extrapolation of the data, the percentages and data from this heterogeneous data into the whole populations may not be relevant.
You are very much right. But my answer to that would be to ask you, suppose you have only one study, how can you extrapolate?
Right.
So it's always better than one study, right?
Right.
So that's all I can say. It is not perfect, but it's more than, it's less imperfect than a single study.
Right.
So that's all we can say.
So yeah, I've read that like meta-regression analysis can be done to decrease the heterogeneity of the case series.
Yeah, that is true. Now there are so many, because of computing power is increasing, statisticians are inventing new ways of looking at this problem. So you can do meta-regression, all those techniques are there. Of course, if people are interested, these are very complicated topics, but if people are interested, I can give a kind of a talk on that at some point of time.
We'll definitely take you upon your offer, sir. We will start a systematic review. Definitely take your help to do the meta-analysis.
I think, this applies to all postgraduate departments. I think it's a good thing to exercise to involve the residents in a meta-analysis, at least in a systematic review exercise, because nowadays you have this access to large databases, and they should know how to do this. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, Kamala madam. And now, sir, can I ask 2 questions, sir?
Sure.
Actually, sir, is there a minimum number of studies that you need to do a systematic review? Things is it something like that, sir?
Then I don't know. I can't answer that straight, but at least I'm not aware of that. In fact, I have been involved in a meta-analysis. Somebody, I mean, this is not a pediatric question. Somebody from the UK wanted to do a meta-analysis, the use of growth hormone in patients. He's an endocrinologist. He's from Kerala, and so that is why he approached me. So in that study, finally, we had only about 4 studies. I mean, finally, after all the filtering, we got only about 4 or 5 studies for doing the meta-analysis. So and it got published. So which means that it is okay.
Sir, one more question, sir. Sir, you were telling that this study is okay and our reviewer was analysis. The person who did the analysis was showing the tabular column of the analysis center. Sir, taking into account all the numbers, do we have a scoring system or something like that to tell that this is good, moderate, I mean, very good, things like that, sir? So how can we just comment it rather than
bias assessment tool has some kind of, I mean, I'm not a very up to date on that, but I think the bias tool has something like that. Maybe the postgraduates who did that, there is a scoring system for that, right? For each study.
Do we have the answer? Or?
Not aware of that, sir. I'm also not sure. So finally putting the tabular column with so many ticks and wrongs in that.
Yeah.
So how good is it or how bad is it? I really don't know whether that's
I think one of the things is if the tool doesn't apply, then you have to supply the whole data and let the people judge. That's all.
Okay. Yeah. Okay.
I mean, all work under a lot of imperfections, but that is something accepted. You should kind of try to do whatever you can do within the imperfections. That's all you can do.
But sir, selecting such an article and dissecting it in such a way in this journal club is actually, that is very useful to all of us actually, sir, because we really get to know how to assess and all. So that will be helpful in doing the analysis also, sir. Now I would like to request.
Selection has been excellent. I think this is a very good article to.
Sir, I would like to request Dr. Padmanabhan sir to give his thoughts, sir. Sir, you are muted, sir. Sir, nope. You are muted, sir. Sorry. Sir, you have to unmute, sir. Please. Thanks. Okay.
Yeah. Many of the things which the postgraduate students told today and also in the trial run was news to me. Anyway, that was a good learning experience for me. But only thing which I would say is 1 or 2 points. When there is an Indian review of literature, at the end, I would have liked them to say what is the difference from the known international studies. That is something which they did not say. The only thing that they said is that the mortalities in India is about 10% and the Western literature is 2%. And that is understandable because for tertiary care is required in severe cases of MIS-C, which is not available for more than 95% of our population. Echocardiogram at the point in time, even ECMO and ionotropes, pediatric ICU, simply not available in most of the population. That might be the reason. But I would like to know the incidence of shock, the other features. You know, MIS-C was one of the definition, if I remember rightly, according to CDC, the patient requires admission, severe enough for admission. But nowadays, more and more MIS cases are coming out with mild symptoms also, with high CRP, with problems like that, which they do recover. Therefore, there's a whole spectrum. It's a work in progress. And at the end of an Indian review, I would have liked them. I would stress it again to know, because as a clinician, how is it different from the known Western literature? Because there's so much published in the Western literature. That's all I would say. Thank you.
So we have looked into a few of the international systematic reviews and case series, but there is so much difference in the selection criteria. So one of the systematic reviews plus contained case series from US and Europe. But there also the diagnostic criteria was so different. They didn't use the WHO CDC criteria. Some use RCPCH criteria for diagnosing MIS-C, and some were a couple of them were referral units taking only cardiac cases with ECMO there. So all of their cases were cardiac. So there is so much heterogeneity in the data. So I didn't see a very similar series with so much, which really pooled from so many places from one single country, or from similar data I didn't find anywhere. But there has been like some case series with less than 2% mortality, but there are others also who have published 6 to 7% mortality, but none as high as what we have reported. Probably one thing will be different centers having different policies, late presentation. So even missed with late presentations can have high mortality, which was, as Padmanabhan himself was mentioning a case from PRS, which initially it was completely missed and then later presented as missed. So late presentations have higher mortality, as we have noticed. And there is, so no single number which is common in these Western studies. So very difficult to compare these studies with an international study, sir.
No, what I meant was that they should have said at the end, it's not international studies. If you look at the MIS-C literature, they say so much percentage shock, so much percentage cardiac, so much percentage aneurysm. They do mention it even though as in to look at up to date or something like that. And where the Indian literature totally different from that in any sense. That's what I meant. Anyway, that's fine.
Right. Majority of these numbers are very similar to what have been published from China and some of the countries. But I mean, when there is a multi-site systematic review involving US, US and European countries, there are so many numbers were different. So couldn't really compare these with them. But many of those mucocutaneous, for example, the mucocutaneous presentations, very large number of mucocutaneous, that is common in all the case series. Cardiac also, around 50%. Most series, they're put in the same number. But the inotrope use, then steroid use, IVIG use, all these were so many different in the different centers. And there was another recent published articles in IJP which said that no use of immunomodulators, mortality will be high. But use of some either steroids or IVIG or both, actually the mortality is very low, but it doesn't compare between these modalities like IVIG alone, steroids alone, or the combination. So all of them have similar mortality than when compared with no immunomodulators. So it is still a dynamic document. So many evidence are still yet to come. So consensus is not yet reached regarding the management also.
Thank you, madam. Madam, regarding the shock also, when we compare this meta-analysis with other studies from abroad and all, is the incidence higher in those studies? Can we tell something like that, madam?
They have the incidence of inotrope use. They haven't mentioned shock per se. Inotrope is almost similar. But as you said, there has been some data from mainly cardiac units, which said more than 80% use of inotropes like that. Yeah, so Anju, I also don't know exactly what the comparative numbers are. But in this study, it mentions around 49 or 50% inotrope use, except for one center with more than 80%. Yes, this is comparable to most of the case series.
Thank you, madam. I would like to request Dr. Purushothaman sir to contribute to the session, sir. Please, sir.
It was an excellent presentation by Dr. Ancy and Amina, and actually I think why should all this credit goes to the Trivandrum people only? IAP should take up, and this journal club should be like this throughout all the state throughout. And I agree with the comments by Ramankutty sir. Excellent teachings also on for the faculty of Ananthapuri also deserve that credit. Ramankutty sir, poyo.
I'm very much here.
Sir, I have a doubt here about the this meta-analysis and this review, systematic review, whether a condition which is varying from April 2020 to December 21. And if you take a little forward all these 8 months, the total incidence and the spectrum and the mortality profile has totally changed from January to August of 2022. So an entity which is changing over time with the agent factor dependent. There are 3 variables which changes the thing throughout. If you take from April 2020 onwards, the first 3 months from January to April was by the original strain. Nobody reported this MIS-C. Then came the UK, the alpha. Then we started reporting it, and beta, gamma, and then the delta wave in 2021 from June to September, you got a maximum number of cases. All these things were varying depending upon the different agents. And over time, there was an increase and betterment of the understanding of the problem, management, everything was changing over time. And is a meta-analysis is justified or will give the true data for when such a thing is varying over time? That is my thing. And another thing, just like I was wondering, the 10% mortality. The 10% mortality, if you're extending, if you're considering this thing over these 8 months, now the mortality is almost less than 1%, not even 2%, I think. If you take that Omicron and the variants now, the majority, 95% of the cases are mild, and there is no need even to give the steroids also. There is no severe cases. The mortality is not the early reporting because the detection and the treatment awareness has made a lot of difference, and the management part also. So such an entity where it is changing over time, agent related, management related, can you get a comment on this thing, the mortality, all the other things? That is one of my questions.
Okay, I can only say that that's an excellent point. And I think you're very much right. I think that is one of the limitations of this exercise. And I think I should point out to the precedents, and this is an experienced clinician, his experience coming through and his knowledge coming through, which you should note. It's very important. And I would say, as a methodologist or a researcher, that that's an excellent point. That's a very serious limitation of this study, and which nobody has pointed out. So even I missed it. So I frankly admit that I could not catch on to that. And I think that's a very excellent, I think that's a limitation. But with all the limitations, I think it gives us, anyway, they have not put one number. It's not a meta-analysis. They have just done a systematic review. They have looked at what are the results over time. So you can say this is a limitation of this exercise. That's all I can say. So
yes, no so one more question, sir. This thing about Padma sir pointed out, we would have gained more if we got the analysis of the other incidences and also like aneurysm and other things. But what about the death was 10%, and our experience with the death was, here we analyzed death a few months back at the time when the Delta wave was over. Our incidence of the death, actual cases of died without any underlying problems were minimal. At the time, it was 80%.
But
also.
My question would be, did you use the same selection criteria as these people for this, or did you just...
No, sir. It was a presentation by Dr. Priya about the analysis of the mortality of throughout Kerala. It was almost at that time, it was 72 deaths or so at that time. Later, it was 90 so. And out of which 10 deaths were actually attributable to cases without any underlying problems. Majority, 90%, 93% were all underlying problems died. So in a case like this also, rather than jumping to this 10% mortality, what constituted, what was the spectrum of the death also would have been looked?
Yeah, it could be, but I think the thing is that they have certain selection criteria, and that might mean that you have a different population. You have selected population to look at, so that might have inflated the mortality. I mean, that is all I can say at this point of time.
Thank you, sir.
Thank you, Purushothaman, sir. One name is being displayed as Sulekha C. I wonder whether it is Sulekha Madam only. If it is Sulekha Madam, I would like to request Madam also to offer the expert comments, Madam. Sulekha Madam. I think
we will conclude now.
Yeah, Madam is not listening or some problem. Maybe Sulekha Madam is not there. I think as Padma sir said, it is almost 8:45. So I think it is time to conclude and all. So I would like to thank all for that excellent presentation and excellent analysis. It was a very great learning experience with the very important points and great teachers with us. So first of all, I would like to thank Dr. Amina and Dr. Ancy Paul for their excellent presentation. And I would like to thank Dr. Ramankutty sir for his time and his sharing his thoughts. And I would like to.
I'm seriously considering Dr. Ramankutty's offer.
What?
You have offered something, you can't go back. Soon we will be having students. And
yeah, I mean, I'm very happy to be of use to anybody, especially in pediatrics, because that is where I started. So
yeah.
I think at this moment of time, I should also mention that Ramankutty sir has been awarded the memento as a recognition at the 70th Platinum Jubilee Memorial ceremony at Medical College. Congratulations, sir, for that. Actually.
Thank you.
And Kamala Madam for, I mean, for what do you call, for so enthusiastically taking part in our journal club with great training and all. Everybody was agreeing. And of course, Purushothaman sir, actually, sir is regularly attending our class. So something which remains that we should be more careful in preparing and presenting our journal club, because sir is definitely there. And thank you, Purushothaman sir.
You are doing a great job.
Sir?
I think you are doing a great job.
Thank you. And thanks. So Kamala Madam, Ranjit, he was joined from Kodikad, and all the PGs and all the faculties, all the doctors who have joined us in this good day, Sunday at this time. I think we will call it a day and wish you a nice time ahead and a great time ahead. Thank you all once again. Thank you very much. Good night.
Thank you, sir.
Thank you.